Here's the culmination of our lectures on schizophrenia. We're going to be discussing drugs for schizophrenia. All of the drugs that are presently approved for schizophrenia fall into the classification of antipsychotics. They suppress the positive symptoms, the psychoses, the hallucinations, the delusions, but they do not suppress the negative symptoms or the cognitive deficits of schizophrenia. So that's a real challenge for future drug development and discovery. All of the conceptual views of antipsychotic drugs assume that they worked via outside-in pathways, the ones I've been discussing with you for these past few weeks: G-protein coupled receptors, G-proteins, intracellular messengers, their blockade or their activation. Most challenging of all for developing better psychiatric drugs, there's no satisfactory explanation for the therapeutic lag, the 2 to 3 week time course between the time a person starts taking a antipsychotic drug and the time it reaches its full effects. We start with a very famous graph for the classical or the typical antipsychotic drugs. Here in the upper left, this is the correlation between their drug potency measured in cell-free systems or in cellular systems and the average clinical daily dose that is required to stabilize a patient. These are all the first generation drugs. There's chlorpromazine, still used. One second generation drug, clozapine, which we'll talk about in this lecture. For the first generation drugs, the correlation is a lot poorer for the serotonin 5-HT2A and 2C receptors. And there's a very poor correlation for the alpha-1 adrenergic receptors and the histamine receptors. These are all GPCRs. So the question arises, well, how is the effect on the dopamine D2 receptor producing antipsychotic effects? The dopamine D2 receptor is a classical GI-coupled receptor. We've discussed this in many lectures 18, 19, 20, and 21. We've discussed 3 types of downstream effects of GI-coupled receptors. We've discussed the activation of G-protein activated potassium channels and the modification by RGS proteins. We've discussed the effects of decreased cyclic AMP on the electrophysiological characteristics of neurons. And we've discussed the pathway from receptor activation to gene activation. It is simply not known how blocking GI-coupled receptors via either of these classical pathways reduces psychoses. So that's a problem, a challenge. Now, the modern antipsychotics, called atypical antipsychotics, also block other GPCRs, not just the dopamine D2 and also D3 receptors. And here is a classical drug, haloperidol. Here are the atypical antipsychotic drugs: clozapine, quetiapine, risperidone, olanzapine, Sertindol. There are others. It is not known how blocking GQ-coupled receptors reduces psychoses. Each of these drugs has a different set of relative affinities, relative tightness of binding for the G-protein coupled receptors. And the size of this pi segment means that its affinity for that receptor is highest. So some drugs bind most tightly to D1 dopaminergic receptors, which are GS coupled, some to the 5-HT2A receptor, GQ coupled, some to the original dopamine D2 and D3 receptor. This is the conventional antipsychotic drugs. Each of these drug classes has side effects. The conventional psychotic drugs have tardive dyskinesia as a major side effect, a movement disorder thought to be localized in the pathway from the midbrain to the striatum, a devastating side effect of the first-generation drugs, and a major impetus toward identifying the atypical second-generation drug. But those too have side effects. For some of them, weight gain. For others, agranulocytosis, meaning a decrease in white cells, particularly true of clozapine, though it's thought to be less of a problem now than was feared originally. So we have this unsatisfactory picture of having drugs that really do help some aspects of schizophrenia, do not help other aspects, and we don't know how they work. What about drugs for cognitive enhancement in schizophrenia? Here, we're going to go back to nicotine and make the observation that 90% of schizophrenics smoke. Here is Geoffrey Rush playing David Helfgott in the movie Shine. You'll remember that I played you an excerpt from David Helfgott playing the Rock 3. In this movie, Geoffrey Rush typically has a cigarette in his mouth. And here's a YouTube reference to an excerpt from One Flew Over the Cuckoo's Nest, the Academy Award-winning movie based on the novel by Ken Kesey from 1974. This scene has a younger Danny DeVito asking for his cigarettes. So schizophrenics certainly smoke, and they smoke more than typical nicotine addicts. They take deeper breaths, they hold their breaths longer, and they generally seem to extract much more nicotine per cigarette. And schizophrenics are very attached to their cigarettes. Clearly, schizophrenics are perceiving a benefit from those cigarettes. This practice of taking in a lot of nicotine may lead to activation of nicotinic acetylcholine receptors that are lower sensitivity than the alpha-4 beta-2 receptors that we have been concentrating on for our previous discussions of nicotine addiction. And one reasonable suggestion is that the schizophrenics are activating the alpha-7 nicotinic receptor. Indeed, in Mini Lecture 50, I told you about a sensory gating anomaly shared by most schizophrenics, and I told you that it maps near the alpha-7 nicotinic receptor. And so some alpha-7 agonists are being tested for cognitive enhancement in schizophrenia. That's an interesting development, and we'll have to see how that works out. So we have a lot of challenges in drug development for psychiatric diseases, and especially in drug development for schizophrenia.